Good evening, everyone. Welcome to our first Just Birth Equity Roundtable in 2003. In the spirit of truth and reconciliation, Doula Canada acknowledges that we are gathered today on the customary and traditional lands and the enduring presence of all First Nations, Indigenous, Métis, and Inuit peoples. Doula Canada's work primarily takes place on Turtle Island, which has been a site of human activity for over 15,000 years and is the unceded territory of Indigenous peoples. Please take a few moments to find out more about the traditional territories, languages, and treaties of where you are located. You can do this by visiting native-land.ca. As we learn together, we ask that you reflect on the ongoing role that colonialism plays in pregnancy, birth, and parenting in your own relationship to this work. We pay respect to Indigenous birth workers, both past and present, including any of those who may be here with us today. Hi, everyone. My name is Kira, and I am an Equity, Diversity, and Inclusion co-lead at Doula Canada. So tonight we are hosting our monthly roundtable to talk about all things related to health equity and social justice in birth work. And tonight we're focusing on the management of medicalized fatness, otherwise known in the medical setting as obesity or high BMI or overweight, these kinds of terminologies. Tonight we are using fatness to take away the medical stigma that is attached to some of that language. And we're speaking with our member, Katie Cook. Katie uses they, them pronouns. Katie is a fat, non-binary researcher, an auntie, care provider, and certifying postpartum doula. Katie holds a PhD in community psychology from Wilfrid Laurier University in Waterloo. Katie's work uses feminist theory to examine how marginalized bodies are constructed and othered in various social contexts. And Katie's research has focused significantly on weight-based stigma in pregnancy and postnatal care. So we're very, very grateful to have them joining us in this discussion this evening. We also have with us Shandelle Ferguson. Shandelle is a labor and postpartum doula in Nova Scotia. She is also one of our instructors here at Doula Canada, and she's been with us for several years. She has, in particular, some insights regarding to how BMI is used in medical calculations as to the likelihood of success with attempting a vaginal birth after cesarean section. Welcome, Shandelle and Katie. We are very grateful to have both of you here with us this evening. So, as I mentioned in the intro, being medically classified as, some of the terminology that was used can significantly change the manner in which pregnancy care is managed. In your view, based on your experience, can you describe some of the examples that you've seen in these differences in care in the work that you've done?
Would you like me to go first, Katie? Sure. As Kara had mentioned, I've focused a lot of my kind of work and knowledge and research in VBACs in recent years, and trying to find out as much as I could with supporting people through that as myself had a VBAC. And so for people who are trying to have a labor, a trial of labor, a TOLAC, after a cesarean, there's what is used called a VBAC calculator. And there's many things wrong with this VBAC calculator. One of them is race is used in there, but another one that's used that skews kind of the results of a success of a VBAC is somebody's BMI. So you put in your age, which affects how successful you are. It puts in your height and then your weight. And if you're anywhere at all in a higher BMI, your percentage of having a successful VBAC goes down with every pound that you are heavier. So, somebody, let's just say, who has, a healthy BMI in medical terms could have a 75% success rate calculator, and somebody who has a not even a morbidly obese, standing, but just obese, goes down to like 62. And just because of how heavy somebody is, it doesn't make sense to me. So when clients for me are talking about having, a trial of labor, that's hard for me, because I'm like, you can't listen to that. You need to push that aside. So that's one of the big things that comes up for me.
Okay, I have so many things to follow up on about that. But Katie, let's hear from you. What are some of the things that you've seen?
Yeah, so I mean, I just want to take, first of all, a slight step back, because you mentioned BMI right away. And I think it's important to note, like, I mean, I appreciate that it sounds like we're entering the space being critical of the uses of BMI. I have another fat studies colleague. I consider myself, my PhD is in community psychology, but my work is really fat studies, and I'm a fat person. And I have a fat studies colleague who refers to it as basically meaningless information, BMI, instead of body mass index, because the BMI was, first of all, created more than 200 years ago. It was created by a mathematician. It was taken up to be used by insurance companies, and it was made initially based on seeking to find the measurements of, quote unquote, the average man. Of course, everything was created at that time using the bodies of and for the bodies of thin, white, able-bodied, cisgender men. So in and of itself, it's not helpful, and it doesn't actually tell us anything about health or longevity. It's used as a diagnosis. I have a diagnosis on my medical record, which was never disclosed to me, but it's just because of an automatic BMI calculation of obese. And so my doctor then, that triggers a whole cascade of my medical treatment. Just today, I was at a specialist that has nothing to do with body size, and I was asked 3 times about whether or not I have thyroid issues and whether or not I have diabetes. Those are questions they ask people with high BMI. And so I just want to start there, because I think that is what's underlying all of this, right? The fact that BMI is put into a calculation, like you said, Shandelle, that is inherently, first of all, useless and also inherently racist. Fatphobia is born out of racism. Weight stigma is born out of racism. We can't separate these things. And so anytime a tool like that is used in any medical setting, it's setting us up for failure. It's setting us up for saying some bodies are, quote unquote, good and therefore have access to certain treatments, or like to a VBAC, for example, and certain bodies are inherently sick, diseased, at risk, etc., and therefore don't have access to things like a VBAC. I don't remember what the original question was. I just got on my little BMI tangent, because I think that's a really important starting place. So maybe I'll leave it there for now, and we can continue the conversation from there.
Thank you so much for that, Katie. That's definitely not a tangent, and it definitely connects very well with some of the other places that I'm going. So our Director of Education, Sandra McCrone, had hoped to also be here this evening. And I know that one of the things that she wanted to talk about that she's seen in her community is that at the hospital that's local to her, the physician who's the head of the anesthesiology program there will not do epidurals on people over a certain BMI. So all people over a certain BMI are kind of forced to leave that community and birth in like the next larger community at a bigger facility there that can provide them with that treatment. And it doesn't really sound like there's any nuance to that as to whether or not people even want epidural anesthesia for their birth plan. Like, it just sound, like the way that Sandra has described it to me is that it's like, you're over a certain BMI, you got to go to the big city for this. But at the same local facility, they are able to perform bariatric bypass on people, which clearly, obviously people need anesthesia. To my understanding, actually pretty similar anesthesia for that procedure as would be used for pain management during labor. So, putting this together with the, what you've explained, Katie, about the fundamental flaws of the BMI and its, intention of sort of talking about at a population level, calculating risk in a kind of like statistical regression model sort of way that's relevant to insurance companies, not really meant to be used in healthcare. And then Shandelle, the example that you provided with this BBAC calculation, like I'm struggling to understand how your BMI would impact your likelihood of having a vaginal birth after a cesarean. How much evidence is really behind some of this stuff? Like, I'm just like, it's not adding, some things aren't adding up to me, right? Like, it's not clear to me why you can provide anesthesia to somebody for weight loss surgery, but not for delivering their baby. The whole rationale of this VBAC thing, quite frankly, on the face of it, sounds thoroughly mystifying. So, like, when a patient is sitting there hearing these things, like, what kind of evidence is being provided to substantiate these things?
None.
Well,
there's no evidence that they're being given. It's just like, here's what your risks are, here's what your chances are. There's no evidence behind it because the evidence is just not there. So they can't talk about pros and cons versus somebody else because there is none. It's old. It's old theories, it's old methodologies. Like Katie said, it's based on things that are centuries old, and doesn't play any impact at all. So there is nothing being given. It's, thinking about anesthesia, I have clients who they're not told why, but they have to go for an additional appointment to go meet with anesthesia before their labor, and they're not told why. I know why. I'm not going to say that to them and embarrass them, but they're told they have to go meet with anesthesia before their labor so that anesthesia can consult with them on how likely an epidural is going to work. Again, like you said, they may not even want an epidural. Maybe this is their third baby and they've had unmedicated labors, but it's not a question. It's they have to go. And, then there's accessibility to transportation and all those kinds of things that really, really bug me. But they're not told. It's just to get somebody to go look at their back. And then they go into labor and they're asked, oh, did you already meet with anesthesia for a consult before? Like it's degrading. Sometimes they don't even know that they're treated any differently than somebody else. But I know when I'm there watching it, and it's hard to know that there is a segregation, that there is a racism, that there is a bias happening.
Wow, that is bananas. Katie, what are your thoughts on
so many
where evidence fits in here?
Just to quickly respond to what you just said, Shandelle, it's so interesting because I think you posted something about it today. I think it was Kira who posted it on the Doula Canada page, an article that myself and some colleagues wrote about. It was in the Canadian Journal of Midwifery Research and Practice, I think is the order the words go in, about pregnancy and postnatal care for fat folks, not just fat women, but we had trans men and cis women in our study. And that was actually one of the things that having to consult with anesthesiologists and other practitioners. One of the recommendations that came out of that study was having, it was for midwives, but I think it applies to someone in a doula in a supportive role as well, in being clear with someone, not in a stigmatizing way, but being clear with them about why they're being referred out to, let's say, an anesthesiologist, because oftentimes that's what participants said. They didn't know why they were being sent there. And then once they got there, they were treated horribly in incredibly fatphobic ways. So that's an issue. I mean, and that paper was published. We were writing that in like 2017, I think it was published in 2019. So this is like, these are things that are like happening over and over. In terms of the evidence question, the answer is, like you said, Shandelle, there isn't evidence, or it's incredibly outdated evidence. And I think the thing with evidence in medicine in this particular issue, when it comes to fat body specifically, evidence-based is used as a blanket term to refer to things like For example, maybe the epidural won't work, or is less likely to work well on a fat body, right? Or maybe the risk of being intubated and anesthetized is a bit higher for a fat body. Or with ultrasound technology or manual palpation to determine the size of the fetus to avoid, baby being too big before it's born, is not sufficient and fat people end up having bigger babies. All of these things are not evidence for why fat people shouldn't have babies or why people shouldn't be fat. These things are evidence for why the medical field needs to do better, right? We need to be teaching doctors and ultrasound technicians how to do these things correctly to judge the size of the unborn baby, on a fat body. We need to teach anesthesiologists how to do an epidural on a fat person's back. It's just that it might require slightly different tools and slightly different technique, and that requires learning. We have MRI machines that fat people don't fit in. That's a very common problem. I had a friend in another province who was waiting in an ER for 4 or 5 days because they didn't have a bariatric bed, which just means a bed with a higher weight limit on the floor. So they had everything else they needed to support this person, but they didn't have a bed big enough when there's no reason for that. The problem isn't the person's body. The problem is a refusal to treat fat bodies as such. And at the end of the day, then it's a bit different when it comes to people who are expecting, who are pregnant, because they're going to have the baby, right? So you can't say, okay, first you need to lose weight and then you will have access to these things, unless, and this is something we found in the study that article I mentioned is reporting on, it was also about reproductive care in terms of fertility clinics. All of the participants had started with fertility clinic support, and we're often told you can't actually become pregnant until you lose weight. You can't have access to any of these treatments until you lose weight. And what we know about weight loss, whether it's through bariatric surgery, whether it's through yo-yo dieting or weight cycling as we call it, is that it doesn't work. 90% of people gain weight back after 1 year and often gain more weight back. And so a doctor wouldn't prescribe, a medication that doesn't work 90% of the time after the first year, right? If I'm experiencing a physical condition, they're not going to prescribe oral medication to me that doesn't work 90% of the time. So why would I be prescribed something that doesn't work 90% of the time in order to have access to these things, rather than improving the evidence, right? Improving training so that practitioners are capable of treating fat bodies, so that the physical, whether it's one of the things that came up in our study was even having wheelchairs that were wider for fat people who need to be transported in a wheelchair from a waiting room to labor and delivery, or to the postpartum wing or whatever it was. All of these basic things that bar people from giving birth in their community, not because their bodies are the problem, although that's the story we're told, but the facilities and the training of the people providing care are not up to par for fat bodies and other bodies as well, but in this case, fat bodies.
And when you say that, I think about bathtubs at the hospital for people to labor in, and when you're in labor, you want to move around, but when a bathroom is a standard size bathtub, that's not going to be comfortable for somebody who's laboring who is fat. So you're right, it's the facilities, it's not the person, which is made out to be like them, because then they feel that they can't get in the tub, which is good to have during labor.
And the question about, the first question that you started with on this question, which I think is very important, about anesthesiology and being sent to a different community and not being able to be anesthetized if you're fat, that is based in the same stuff. Yes, there are higher risks with being intubated and anesthetized when you have a higher body weight, but those risks largely come with lack of appropriate equipment and lack of appropriate training with anesthesiologists. They're not inherent to everything, all things equal. Well, all things are not equal. Bodies are different, right? But some bodies are big, some are little, everything in between. And people are denied all sorts of surgeries, whether it is, whatever it is, based on body size. They're told you have to first have weight loss surgery or stomach amputation before you can have gender affirming surgery, cancer surgery, whatever it is. So this is in the realm of people seeking, not even if they're seeking an epidural, like you said, but you might need an epidural, and we can't give you an epidural or anesthetize the fat body, so you need to go however many hours away to a community where you have no support in order to birth your child.
Thank you so much for what you've both just shared. There's so many important threads to pick up on there. I want to touch on the piece about provider training and competence with working with fat bodies, and related to having the right equipment as well. So somebody that I know told me a story about one of their birthing experiences, where they are a fat person. And when they were having their epidural placed, the anesthesiologist asked them to identify where the epidural space was on their back, which is like, I don't know how many people without the training of an anesthesiologist, quite frankly, would really be able to do that. Like, it just seemed like such a bizarre request to me to put that on the individual to identify where the location is. So, of course, that left me sort of feeling doubt as to whether or not this person would get effective epidural analgesia medication, whatever, from a provider that needs to ask them where the appropriate location for the placement is. So in our work as support people, right, like we're not the people placing the epidurals. If we see something like this going on, how do we disrupt that? Like, what would effective support with some of these absolutely untenable situations, right? What would that look like? I'm curious with some of these protocols. It sounds like clients are most often presented with this information as though this is just what's going to happen. They don't necessarily know that their experience is different from that of other people's. What would happen if people said, actually, if you can do this for somebody who's getting bariatric bypass, stomach amputation, as you said, why can't you do the epidural for my birth? Like, what does it look like to try to challenge some of these systems, and how would we support people to do that?
There are a lot of, first of all, there are a lot of resources online for whether it's self-advocating as a fat person, which can be helpful. I mean, as a fat person, I will say I love it when I haven't had a care provider do this. I've had one do this, but they weren't physical health care provider or mental health care provider. Do the research and access tools. So there's, I can find it. There's a fat activist named Reagan Chastain who has put out like cards that you can bring to the doctor's office, and a lot of the questions on this card, or a lot of the self-advocacy would also relate in spaces, medical spaces related to birthing as well. All might not, but questions to ask in order to challenge those things, because it's also really hard to do in the moment. There's also the Association for Size, Diversity, and Health, or ASDA, which is American-based, but is a wonderful organization, and they host so many tools. They have a new tool out for during Black History Month about racism and health at every size. So they have a lot of tools around health at every size, and health at every size is really a framework for care practitioners and fat people. So a lot of their materials are not just necessarily for fat people self-advocating and doing the work for ourselves to seek body fat liberation, but for care providers who may of any size to be able to do that work. So I highly recommend, I'm happy to share links to ASDA, Association for Size, Diversity, and Health. I think what it comes down to is, first of all, having open conversations with people and not shying away from conversations. I think one of the things I've heard the most and read the most in the literature is that, care providers don't want to make anybody uncomfortable. And we also don't know, right? Especially I think if you're a thin practitioner and you're sitting in a room with a fat pregnant person, you don't know what their experience of fatness is. You don't know what they're feeling about. Like, I use the word fat very happily because that's what kind of body I have and always have had, but not everyone feels that way, right? Some people are not comfortable with that word. They prefer other words, or maybe are actively trying to lose weight and hate being fat. Like, I don't know, we're all over the board. So I think it's coming to those conversations with a critical lens, but with an openness to find out where that person's at. And really, at the end of the day, no matter how the person feels about using the word fat or about their body, they don't deserve to be treated like crap, within healthcare settings, within birthing settings, purely because of the size of their body. And I think it's reminding folks of that and acknowledging that these are systemic issues, and the problem isn't them. The problem is this lack of training, this lack of facilities, a lack of knowledge, really, for everybody, not even just for doctors and nurses and midwives and et cetera, right? I think those are some kind of rambling places to start, I think, is what that is.
Awesome. Thank you so much. And yeah, it would be fantastic if you could share those links. I'll add them in the comments of this video. Shandelle, what are your thoughts on that question? You know, when you're working with a client who's been told that they shouldn't even bother to try for a VBAC, they should just go ahead and schedule the C-section. What does challenging that look like? Can it be done, right? Like, is it possible for someone to actually insist that no, they're not booking the C-section, and they deserve to get to try to have a vaginal delivery as much as anybody else?
Yeah, and I'm all about kind of, chatting with them and first of all asking them, how do they feel about that? And then if they're, maybe they've decided that, another cesarean is right for their family, great, I'm going to support you through that. But if their heart is still telling them that, their goal is to have a vaginal delivery, then let's work through how that happens. We do have a lovely person who works at the hospital here that is a clinical nurse specialist. And when things come up like this, she is the person who I recommend most people contact, because she will kind of help facilitate conversations with the different OBs that are involved and things like that, so that these things can happen, because sometimes it's a lot of pushback from the OBs. We have a couple of different models of care here who support families through labor, and usually, and I hate to say it, but usually a lot of the resistance comes from the OBs. And so the clinical nurse specialist can help facilitate those conversations so that the person feels heard, can definitely move forward with what their wishes are, and be kind of an unbiased person that's not there for the patient, but not there for the doctor either, and kind of work through that. However, I am all about, let's talk through this, and this VBAC calculator needs to be thrown out the window. And the minute that somebody tells me that their doctor talked about a VBAC calculator, I am telling them that it's outdated, that it's not used anymore. It's not used. It's not what's used. And so I build them up and, totally let's talk about it. And even if they say that if their risk is, their chance is 50%, well, you know what? That's zero. That's better than zero. So 50% is 50%. So we're going to work with those things, and let's make sure that these things happen. And so, it's really just about encouragement and, really talking about what matters. And this VBAC calculator doesn't matter. The size of their body does not matter. And so that's really where what I feel that I do the most is just that encouragement piece and kind of talking about what actually matters. That statistic about their body.
Amazing. Thank you so much. That's actually a really wonderful practical tip too, Shandelle, both in terms of how you coach the client, but then also in terms of the systems that you navigate, knowing where the allies are, like knowing who can go and support those conversations with the OB, who will get some traction, right? I think that's a really useful piece. I do see that there are a couple of comments in the chat. I'm just going to take a quick look and see if there are any questions for our guests. Yeah, I think that one of these comments ties in really nicely with what you were saying, Katie, about how the system creates some of the risks that it's warning people against. This commenter is saying that it's kind of a self-fulfilling prophecy element to it, where if the medical system is showing the pregnant and birthing person and doubting their ability to birth, that doesn't really empower them and create psychological safety, right? That's going to fuel that person's own doubts and make a poorer outcome more likely. Do you have any thoughts to add to that? Like, how much is the psychological stigma piece a part of the risks that happen here as much as anything else?
I think, I mean, it's because it's stigma that isn't even just psychological, right? Like stigma sits in our bodies and literally affects our health, like stress levels and high levels of cortisol over time. We know these things have a detrimental effect on bodies. And the thing is, when somebody, I would say maybe almost always, when somebody's getting to the point in their life where they're a fat person and they're pregnant, or they're looking to get pregnant, or they're about to give birth, that is not their first experience interface with medical professionals. And we as fat people have lifetime. Some of us, I mean, myself included, I was a fat child. My dissertation is about people reflecting on being a fat kid and how weight stigma, how they learned about weight stigma. And most often it was in doctors' offices. They were brought in with strep throat, and the doctor said, well, what you need to do is lose weight. So eat half of what you're eating. Literal quote from a doctor to a 6-year-old child. If you're eating 2 pounds of bacon right now, eat 1 pound of bacon. If you're eating 2 loaves of bread, eat 1 loaf of bread, and you'll lose weight and then you'll be fine. They went in for a sore throat, right? So we experience these things. Not only are they self-fulfilling prophecies within the interactions with OBs and even midwives, but definitely OBs are a bigger source of this stigma, and other medical doctors. We come from lifetimes of these interactions. And so we are set up to believe we're going to enter a space, whether we're critically aware of it or not. We know we're going to go into a space and we're going to be told that our body is the problem and that we're high risk. I've been told I'm high risk at least once today by a doctor, like I said, for something that I wasn't even there for. Like, I have nerve pain. Why are you talking about thyroid? My thyroid is fine. They check it every 6 months because I'm fat. Like, it's never been a problem, So we're constantly told our bodies are the problem, and that has an effect on our psychological health. It has an effect on our emotional health, and it has a big effect on our physical health. And is actually one of the things we write about in the article that I mentioned, is that these things have an effect on some of the negative outcomes that fat people can experience when they're pregnant, like gestational diabetes, like higher blood pressure. These are also results of stress on the body that comes from long-term experience of weight-based stigma. So yes, the answer to that is absolutely yes. And it's not even just within birthing, it's a lifetime of this stigma in our bodies and on our bodies.
Thank you so much, Katie. That's a fantastic insight into this. Obviously, there's a lot to unpack here, and people want to be engaged in this discussion and know more about it, because I'm seeing another question here in the comments. Somebody's asking what would be helpful advice to doulas who have clients that believe the stigmas and begin to doubt their ability. So I think you've both touched on this, that sometimes this becomes very internalized for people, and access to a critical lens around what they're being told isn't necessarily something that everybody has. What are your, how would you respond to this question? Either of you can jump in, perhaps Shandelle, since we didn't hear from you the last question.
Katie's just so filled with knowledge that I'm just like, I'm learning.
I get fired up. I had to take my shawl off. I was so fired up.
Yeah, no, I want to hear your thoughts on all of the questions, Shandelle. I'm also keeping an eye on the time, but this conversation is so lit, and people are obviously really into it. So that's great.
And I think that touches on what I said before about just empowering them, and again, asking them how they feel about it. That's the first piece. And then, because I don't want to bring my own thoughts and beliefs and things on people if that's not what they believe. So first of all, asking them what they believe, and then talking about what these decisions and what these suggestions are rooted in, and so that they are aware of, that this isn't necessarily medical advice. This is, very stigma based. And so that they're aware, and that maybe that gets their wheels turning and seeing what's happening, and then we can have a bigger discussion about it, because they need to know. They need to know risks and benefits of not only things that happen in labor, but also what's being told to them to make decisions about labor and birth and postpartum. So I think that's the biggest thing, is just letting them know where this information is coming from and empower them to make the choices that are right for them.
Thanks so much for that, Shandelle, because I think the question of risk is so interesting here, especially with the VBAC piece. I mean, not especially with it, with all of this, but I'm thinking about with VBAC and that there are some specific risks to that cesarean site incision from having a VBAC that are, to my understanding, more prevalent if you are a fat person. So even just, I have so many follow-up questions about where some of these risk assessments lie as to what is actually more concerning or not. We could talk about this for a long time. I think there's a lot to unpack here. So I think we're definitely going to have a part B to this discussion. Thank you so much for opening up this dialogue. I'm going to say we opened up the conversation about this today because there's obviously so much more to say. But this has been really helpful and really practical and informative. So I thank you both for your time in this conversation.
Thank you.
Thank you.
Thanks for the great questions.
Yeah, and thank you so much to those who participated in the chat. That was really enriching. All right, have a great evening, everyone. Thank you so much to everyone who joined us for our first Just Birth Roundtable in 2023. We'll be back in March talking about fertility Hunger Games and some of the inequities in access to accessing fertility care and treatment. All right, have a great evening, everyone.